very kind introduction, and it's my great honor and pleasure to have an opportunity to at this prestigious meeting. And actually, this is my third time to Vietnam and second time to Hanoi, and I'm always feel very comfortable when I visit Vietnam. And today I would like to talk about the diagnosis of the Crohn's disease, especially focused on the early diagnosis in ASEAN patients. This is my disclosures. So everyone knows about the ulcerative and the colitis and Crohn's disease, two representative forms of inflammatory bowel disease. And Crohn's disease can involve the whole GI tract, and although the ulcerative colitis can involve the superficial layers of the colon, Crohn's disease has characteristics of transmural inflammation with skipped inflammatory patterns, and patients usually present with abdominal pain, weight loss, and diarrhea, and perianal problems. And as covered by the previous speaker, both Crohn's disease and ulcerative colitis develops in the very, very young age, and it is lifelong chronic disease without definite cure. And because the Crohn's disease has a relatively low mortality, the number of patients is gradually increasing, and we need to focus on the lifelong management of the patient with Crohn's disease. And it is not limited to bowel only. It has multiple extraintestinal problems, including joint problems, skin problem, eye inflammation, etc. And if patient has a long-standing uncontrollable inflammation, patient can have the kind of the malignancy such as endorectal cancers. Yes, UC is increasing worldwide. In Western countries, the incidence of the IBD is relatively stabilized. But as you know, the incidence of the UC is increasing in Asian countries, and this is the situation of Korea. And same for the Crohn's disease. Although we have still lower incidences of the IBD in Asian countries, it is steadily and gradually increasing. I think it will be the same phenomenon in the Vietnam and Southeast Asia. And this map shows the worldwide incidence of ulcerative colitis. Unfortunately, I found that there is no clear statistics for the incidence of ulcerative colitis in Vietnam, and the same for the Crohn's disease. I think that you will have the more clear statistics of the IBD incidence in Southeast Asia, including Vietnam. As shown by the previous speaker, and the IBD is increasing in Korea and the other countries in Asia, and the upper part of the slide showing the increasing incidence of the Crohn's disease and ulcerative colitis in Korea. And actually, year 2020, in our country, we have around 25,000 Crohn's disease patients nationally. And the same trend is also shown in Taiwan. 2 years ago, we published an IBD fact sheet in Korea, and I will show these statistics briefly. And this is a nationwide data combining the ICD code and the V code. V code means the code given to the patient with inflammatory bowel disease, because inflammatory bowel disease is rare and intractable disease. And for the 10 years, as you can see in this graph, the number of patients with Crohn's disease and ulcerative colitis increased by over 2-folds. For Crohn's disease, it increased by about 2.4-folds over 10 years. This is the cases of the new IBD patient diagnosed year by year. And in 2019, about 1,800 Crohn's disease patient was newly diagnosed in Korea. How about age of diagnosis? I think that will be the same in Vietnam. And the peak age of diagnosis of Crohn's disease is 20s in both male and female. And you can see this pattern of the high incidence of the Crohn's disease in young age group. Crohn's disease etiopathogenesis is not so clear, and we know that there is a clear genetic predisposition for patient, and there is some abnormal immune response between host and gut microbiome, and environmental factors like smoking and pollution and stress can contribute to the development of inflammatory bowel disease. And we know that there is a preclinical stage of inflammatory bowel disease. And even in the preclinical stage, inflammation starts and there is an abnormal immunological interaction between host and the gut microbiome. And if patient have some symptoms, we can diagnose as Crohn's disease. And after Crohn's disease, if we do not treat patient properly, accumulation of the bowel damage is progressed, and it is very, very difficult to treat patient without complication, even in the advanced stage. Next one is diagnosis. So why is early diagnosis of Crohn's disease so important? This is gross picture of the Crohn's disease and ulcerative colitis. As I mentioned before, ulcerative colitis is relatively superficial disease, but Crohn's disease is a transmural disease. And at the first stage, there is only inflammation, but if bowel damage accumulates, patient will have the various complications like fibrotic stricture and penetrating complication leading to abscess, interbowel fistula, enterovesical fistula, etc. So before development of that kind of the complication, we have to control disease. This is a very famous cartoon showing that 3 pillars of IBD care in modern era. The first one is early intervention. Next one is T2T approach. And the third one is tightened monitoring. And by combining these 3 strategies, we can change the disease of IBD, especially Crohn's disease. And because Crohn's disease is a lifelong illness, it is very important to communicate with patient continuously. To do an early intervention, I think that early diagnosis is very, very important. Before we apply early therapeutic intervention, early diagnosis of Crohn's disease before progression of digestive damage is very, very critical. This is the new concept, old concept and new concept of the IBD management. And we know that IBD is a progressive disease, especially Crohn's disease, a progressive disease. And previously, we treated the patient all the same way, but in this area, individualized therapy is important. Previously, we focused on the clinical symptoms only, but now we are treating not symptoms, and beyond the symptoms, we are treating inflammation. So we have to utilize more objective target and objective tool for monitoring of patient. And as I mentioned by Dr. Luan, accelerated step of top-down strategy is needed for patients with poor prognosis. And we also need to apply tight monitoring. So Crohn's disease is a progressive disease, and this is very, very famous cartoon showing the progressive nature of Crohn's disease. As you know, the patient symptom can show waxing and waning, and patients have no symptoms at some stage, but even that stage, bowel damage is progressively accumulates, and finally patient requires surgery because of the stricture or penetration. And there is a definite window of opportunity here in the early stage of diagnosis, and because all of the drugs we are using for Crohn's disease is anti-inflammatory agent. That means that all drugs are controlling inflammation, but if fibrosis or penetration develops, that drugs do not work. So we need to control inflammation before development of this kind of the complications. If we treat patient properly, we can show this type of graph, patient course, without progression of bowel damage. This is very famous graph showing the natural course of Crohn's disease in France, showing including more than 2,000 patients in France. And as you can see in this graph, over 20 years, patients with inflammatory behavior decrease gradually, and patients with penetrating or stricturing behavior increase gradually, especially penetrating complications. So because of this kind of complication, so many patients require intestinal resectional surgery. So if we treat patients in the early stage, we have high potential of modifying disease course. And if we patient in the late stage of disease, anti-inflammatory drugs do not work for in this stage of patient. That's the problem. However, unfortunately, even in Korea, we are diagnosing patients with advanced disease stage. And when we analyze data of the population-based IBD cohort study from Songpa Gangdong district of the Seoul, about 20% of patients had already complicated behavior at the time of diagnosis. So we have to reduce this proportion of patients with complication at the time of diagnosis. So I would like to cover the diagnostic delay in Crohn's disease in several studies. And in the Swiss IBD cohort study, they analyzed the interval from symptom to IBD diagnosis. And as you can see in this slide, the interval was 9 months for Crohn's disease and 4 months for ulcerative colitis, and it was statistically significantly different. And it was the same for the Romanian national registry. And Crohn's patient had more diagnostic delay compared with patients with ulcerative colitis. So what are the risk factors for diagnostic delay in Crohn's disease? And there has been a Swiss IBD cohort study, Romanian study, Indian cohort study, and small-scale Korean single-center studies. And diagnostic delay was defined as the interval from symptom to diagnosis as 18 months or 24 months or 21 months. And these are the risk factors for the diagnostic delay. And common risk factors were ileal disease. And in India, anti-TB treatment was risk factors of diagnostic delay. And in Korean studies, perianal discomfort as initial chief complaint was also risk factor of diagnostic delay. What are the outcomes of diagnostic delay? Yeah, this is the outcomes of diagnostic delay, and we can expect these are poor outcomes. And if patients have diagnostic delay, more patient requires intestinal surgery and more patient showing valve stenosis. So we need to make an early diagnosis of Crohn's disease. Next one is Crohn's disease diagnosis. This is very difficult to make a proper diagnosis because there is no single diagnostic gold standard criteria for diagnosis of Crohn's disease. First, we have to be focused on the patient feature, demographic features, because in most studies from West and from East, Crohn's disease develops in young age. There is a small peak in old age, but this phenomenon is not universal in Asian studies. So if we summarize the peak age of the diagnosis among Korean, Japan, and Chinese and Thailand studies, as you can see, the peak age of Crohn's disease diagnosis is 20s or teens or 30s, mostly 20s. So if patients have Crohn's-like symptom in very old age, there is a lower probability of Crohn's disease diagnosis in that population. Symptom, the abdominal pain and weight loss and diarrhea are three major symptoms, but the symptoms start very, very insidiously, and patients have chronic symptoms usually over 6 weeks, and symptoms shows wax and waning patterns. So if we see the patient suspected of Crohn's disease, we have to make a detailed history on that patient, including symptom onset and characteristics of symptom like nighttime abdominal pain and recent weight loss. And some patient is confused with irritable bowel syndrome, even in Korea and even in other Western countries, and we have to focus on nighttime pain and weight loss and abnormalities, because these features is not common in irritable bowel syndrome. Differential diagnosis is very, very difficult in some cases, and we have to focus on patient presentation like orogenital ulcers, extraintestinal TB, history of medication including antibiotics, NSAID, and patient demographics suggesting the ischemia, and previous treatment like radiation or diversion. What are the signs of Crohn's disease? Usually, because Crohn's disease involves lower area of the bowel, patient have pains in low quadrant, and if complications develop, we can palpate mass in low quadrant. Another thing is perianal examination. I think that it is very important to take a history of perianal problem and make a physical examination on the perianal problems for patients with Crohn's disease, because some patients develop perianal disease before presenting GI symptoms, and about 10 to 15% of patients develop perianal problem first before presenting with GI symptoms. As Dr. Luan presented in his data, I heard that about 27% of the Vietnamese patients had perianal problems, and this is summary of data on the perianal disease at the diagnosis of Crohn's disease. It is quite high compared with Western data, and in Korean data, we had over 40% of patients have perianal disease at the time of diagnosis, which is quite high compared with Western data. Recent meta-analysis also suggested that there is a difference in the prevalence of perianal Crohn's disease according to the ethnicity. As you can see in the graph, Asian patients have higher prevalence of perianal Crohn's disease compared with the Western patient. This also shows the high proportion of patients with the perianal Crohn's disease, and in Korean nationwide population-based study, about 40% of patients had a perianal Crohn's disease, which was quite high compared with Western data. Laboratory finding is very, very non-specific, but almost over 90% of patients have any abnormalities in CBC, chemistry, ESR, or CRP. And for differential diagnosis with IBS, we can utilize fecal calprotectin, but I was informed that fecal calprotectin is not so easily available in Vietnam. ENCA is not essential for diagnosis of Crohn's disease, but it will be helpful for differential diagnosis in some cases and for prognostications. Endoscopy is essential, and I think that all of you are the specialists in endoscopy, and colonoscopy is key for the diagnosis of Crohn's disease. And when we analyze the findings of the colonoscopy, we have to consider multiple factors, including location and distribution of lesions, continuity of lesion, direction of ulcers, and mucosa around ulcers, and other features. Because disease have the preferential area of inflammation, for example, intestinal TB and Crohn's disease and GI Bechet disease, Yersinia enterocolitis commonly involves ileocecal areas, and other diseases have their own preferential areas of involvement. You know the various colonoscopy features of Crohn's disease, including very early lesions and very typical longitudinal ulcers, gallstone appearance, and perianal skin tags and perianal abscess. And if diagnosis delays, we can find the stricture or penetrating complication like these endoscopic features. We have the various features of the inflammation, including very small ulcers and geographic ulcers and typical longitudinal ulcers. This is showing the various features of longitudinal and geographic ulcers in Crohn's disease involving colon and small intestine. Gallstone appearance can be found in very severe Crohn's disease cases, but it is not pathognomonic for Crohn's disease, you know. When we do an endoscopy, we have to check the perianal problem because we can find the very severe perianal involvement in some cases of Crohn's disease. Differential diagnosis with TB is very complicated and very challenging in some cases, but there are key differences between Crohn's disease and intestinal TB, including transverse ulcers in TB, petulous IG valve, and very frequent scar change compared with Crohn's disease. Previously, we had a problem of misdiagnosis of Crohn's disease as intestinal tuberculosis. And so many patients was misdiagnosis as intestinal TB. And I think that it would be the problem in the Vietnam as well. But in these days, we have more cases with intestinal TB and misdiagnosis with Crohn's disease. And this is important because TB can be cured with anti-TB therapy, but Crohn's disease requiring lifelong treatment with immunomodulators. It is not easy to differentiate between two diseases, but generally speaking, abdominal pain, weight loss, and diarrhea, rectal bleeding is slightly more common in Crohn's disease. And perianal disease is much more common in Crohn's disease. There is some few cases with perianal abscess by TB, but most cases with the perianal abscess is Crohn's disease, I think. And we also have to check the TB in other areas of body, including lung and peritoneum, etc. When we're looking at the cases of Crohn's disease, initially misdiagnosed with intestinal TB in our center, patient age was younger, and the median age was 23 years, and the diarrhea was dominant, and patient with asymptomatic presentation was very, very rare. And finally, patient finally diagnosed with intestinal TB had more cases with without any symptoms compared with the binary Crohn's disease group. As I mentioned before, active perianal fistula was more common in the binary Crohn's disease, and active TB was observed in about 13% of binary intestinal TB group. All the TB was observed in about 1/4 of the binary ITB group. Because endoscopy is crucial, we have to differentiate between two diseases focused on the features favoring Crohn's disease in left side and features favoring intestinal TB in right side, like fewer than 4 segment involvement, transverse ulcers, patulous ileocecal valve, and scars or pseudopolyps. We can differentiate between two diseases over about 90% of cases. In addition to endoscopy, we can utilize chest X-ray and abdominal imaging because typical Crohn's disease show the skipped pattern of the longitudinal ulcers, but it is not common in Crohn's disease. And abdominal lymphadenopathy is more common in intestinal TB, especially caseous necrosis. Histology and microbiology can be helpful in some cases, but the K18 granuloma or AFB and culture positivity is usually not so common, especially in our data, it was less than 20% of cases. TB PCR, interferon gamma assay, ASCA can be helpful, but in less than 50% of cases. So it is not easy, but we have to combine everything to make a proper diagnosis. And this is our algorithm for the diagnosis of the Crohn's and TB. And we utilized the colonoscopic features here, and we also utilized ESCA and small bowel involvement, especially proximal small bowel involvement, more common in Crohn's disease. And for TB, positive quantiferon TB test and pulmonary TB findings was more common in intestinal TB. And when we combine these features and laboratory radiologic findings, we could make a correct diagnosis of the Crohn's or TB in almost all cases. Upper GI involvement is not so common, and in the guideline, EGD is not essential for making diagnosis of Crohn's disease, but I would like to recommend to do an upper GI endoscopy for proper staging of Crohn's disease and proper classification of Crohn's disease, because the upper GI environment has very poor prognosis, and some patients have the already stricturing or penetrating upper GI features, and in these cases we have to make a more aggressive treatment, and in some cases a patient needs dilatation therapy or the surgery in the early course of the diagnosis. Capsule and enteroscopy is not so commonly used for early diagnosis of Crohn's disease, but capsule endoscopy can be used in well-selected patients with a very high suspicion of Crohn's disease, and it can be used to make a proper diagnosis of small bowel Crohn's disease, who cannot be properly diagnosed after ileoconoscopy and small bowel radiologic examinations. DBE can be utilized at the biopsy of lesions and for therapeutic approach, but it is not so commonly used in Korea as well. The typical virus capsule endoscopy findings of Crohn's disease like this, but the gold standard criteria is not so established. I heard that the CTE and MRE is limitedly used in the Vietnam, but if we use these modalities, we can find the typical findings like longitudinal ulcer, in the mesenteric borders of the small bowel intestine like this. And we also see the features of complicated Crohn's disease in CTE, and the complicated picture, especially in the perianal regions with MRI examinations. Small bowel follow-through is not so commonly used in Korea, like Vietnam. And if we do on this examination, you can see the longitudinal ulcers and cobblestone findings. Same picture can be shown in the CT enterography, and you can see the enteroenteric fistula in these advanced cases of Crohn's disease. And sometimes if the diagnosis is not so clear, we may need a surgical approach at the initial diagnosis of Crohn's disease. And it is a problem that in some cases of Crohn's disease with a very acute presentation, patient go to the surgical clinic, and that patient is misdiagnosed with acute appendicitis, and the appendectomy is performed. And after appendectomy, patient do not getting well. So finally, the patient have complication and post-op complication, and finally the patient sometimes diagnosis of Crohn's disease. And if we do a surgery for Crohn's disease patient, we can find these features, including mesenteric pad lapping, advanced cases, intestinal strictures of enteroenteric fistula. This is a very typical picture of the mesenteric pad lapping in Crohn's disease patient. I think that it is important for physicians to make a correct diagnosis for Crohn's disease, but it is also important for the surgeons, general surgeons, or the bowel surgeons have a proper knowledge on the diagnosis of Crohn's disease. Histopathology is not gold standard. It is supporting diagnosis of Crohn's disease. And there is some typical features for some diseases like a non-caseating granuloma for Crohn's disease. And if we find the caseating granuloma or AFB, we can make a diagnosis of intestinal TB. And some other findings like CMV, MAB colitis, and PMC. If we find these pathologic features, it is more easier to make a diagnosis of each disease, but it is not always the case. This is a surgically resected specimens of Crohn's disease showing the longitudinal ulcers and strictures. And pathologically, it can show the transmural inflammation and granuloma and the patchy nature of the inflammation. But non-caseating granuloma is not so common, and it is observed in less than 50% of cases. And I'd like to stress again, the pathologic diagnosis is supporting, and clinicians' high suspicion of Crohn's disease is more important. Differential between ITB and Crohn's disease, as you know, the confluent granuloma, large granuloma, some mucosa granuloma, and high numbers of granuloma is more common in intestinal TB compared with Crohn's disease. Differential diagnosis, I'd like to show some cases briefly. This is an old female patient with lower abdominal pain, and she had intermittent hematochezia and weight loss, and she had a hypertension and angina. And this is the pictures of the colonoscopy showing inflammation in left-sided colon. Pathologic finding was not so helpful. And this patient actually referred to our hospital with impression of Crohn's disease. CT showed the inflammation relatively limited to left colon, and ileocecal area was okay. So this was finally diagnosed with ischemic colitis. And this is old woman. And old woman means that there is a low probability of Crohn's disease actually. And She had on multiple specters with ischemic colitis. Endoscopic picture was also suggested ischemic colitis. Radiologic features as well, including endoscopic findings and the location of inflammation. So this patient was observed, and the patient finally improved and normalized. If we see this type of inflammation, we have to check the patient history of medication detailed. This patient of long-term NSAID taking history and NSAID-associated enterocolitis was binary diagnosis. In advanced cases, we can find this type of the fibrosis and circular fibrotic change of bowel. This is another cases of the 49 female patient with hematochezia, and she had recurrent bleeding requiring embolization. At another hospital, she was diagnosed with Crohn's disease, and steroid and azathioprine and infliximab was given, but she visited our hospital because of recurrent bleeding. And this is the endoscopic picture of this patient. This patient was finally diagnosed with a T-cell lymphoma, and it is not easy to make a proper diagnosis in this type of cases, but we have to have a high index of suspicion for this type of cases. This is another cases of male patient in age 50. This patient had febrile sense, weight loss, loose stool, and low abdominal pain. This patient was also diagnosed with Crohn's disease in other hospital, but as you can see in these Crohn's pictures, this is not so well comfortable with Crohn's disease, and this patient have very bizarre types of the multiple ulcers in the whole area of the colon. Small bowel double bowel enteroscopy also show the very bizarre shaped geographic ulcers all of the small bowel, and CT show the multiple lymph node enlargement in the abdomen. Finally, this patient also finally diagnosed with T-cell lymphoma associated with chronic active EBV infection. Colonoscopy classification of ileocolonic lymphoma was published in our hospital about 20 years ago. They can show the fungating nature or infiltrative nature, also fungating feature or infiltrative feature. In some cases, shows ulcerative lesion like this. And in these cases, we can misdiagnose these cases Crohn's disease, but please remember that we have to combine every feature, including CTE and the biopsy and patient presentation for making a proper diagnosis. What is the practical tips? It is also difficult in Western areas, and this type of the study was performed in Italy, and they developed on Redplex index for early diagnosis of Crohn's disease. And the important feature was you can see in the yellow box, non-healing or complex perianal fistula abscess or perianal lesion, highly suggestive of Crohn's disease. Family history of IBD also highly suggested Crohn's disease. Weight loss 5% or more in the last 3 months. Chronic abdominal over 3 months, and nocturnal diarrhea highly suggested Crohn's disease. And I would like to emphasize that the detailed history taking is very important in the initial stage. But in the general physicians, the sensitivity of specificity of the Redplex index was not so high. And if we combine p-calprotectin with Redplex index, we could enhance the sensitivity of specificity, especially specificity of diagnosis of Crohn's disease. So high index of suspicion by physician plus p-calprotectin is important. If p-calprotectin is not available, you need to recommend colonoscopic evaluation and radiologic evaluation and the basic blood lab for diagnosis of Crohn's disease. This is my final slide. We have to remember that Crohn's disease is a progressive disease leading to accumulative intestinal damage. And if intestinal damage develop, many drugs like anti-TNF agent, anti-interleukin agent, and anti-integrin agent does not work so well for Crohn's disease patient. So we have to make an early diagnosis and make an early treatment before development of advanced disease. Diagnostic delays increase risk of bowel stenosis and intestinal surgery in patients with Crohn's disease. So early diagnosis is key in the proper management of Crohn's disease. We clinicians should combine every clinical features, clues, and workup result for correct diagnosis of Crohn's disease. And I would like to emphasize you need to make a special focus on the perianal manifestation in early manifestation of Crohn's disease, and some patients, some small proportion of patients with ileal early involvement, which can be misdiagnosed as irritable bowel syndrome. So finally, we are having AOCC and international meeting of CASID in April this year. And this is the homepage of the AOCC. And abstract submission deadline is 27th this month. And pre-registration is the deadline is the end of February. And I would like to invite all of you to submit abstract and make a registration for this meeting. Thank you for your kind invitation. Thank you.